Now, the story of FMT in the last 50 years is closely associated now with Clostridioides difficile, formerly Clostridia difficile, but now Clostridioides difficile, and I'll abbreviate C. diff. And just as a review for you, it's a gram-positive spore-forming anaerobic bacillus, and that little orange inclusion body there is a developing spore within the cell. And it's relevant because pseudomembranous colitis, or acute Clostridioides difficile infection, is as a consequence of this microorganism. On the left, you have a healthy colon. On the right, you see these white plaques, each of which represent clusters of neutrophils that have occurred in the colonic surface. And with this inflammation, you get a profound inflammation of the epithelium and its inability to reabsorb fluid any longer, so you get diarrhea that occurs as a consequence. Now, a brief history of C. diff colitis in the United States. It was described as toxic enterocolitis in children as well as adults in the 20th century. It was associated with the advent of antibiotics in the 1950s and 60s. Initially, clindamycin was the one that was linked, then subsequently penicillin, cephalosporins, fluoroquinolones. Now all antibiotics now are linked to it and can provoke it. Other risk factors being a little bit older, being immunocompromised, underlying disease, proton pump inhibitors. That is to say, the profound suppression of acid production in the stomach eliminates that barrier that allows us to sterilize food. But not long ago, when we used to pick up food off the ground and dust it off and eat it, and that was their principal way of sterilizing our food, was the acid in our stomach. So other risk factors, interesting risk factors for C. diff is being hospitalized, being in a hospital bed that previously had a person with C. diff, and then interestingly, CT scanners. CT scanners are implicated because you can't go through an emergency room right now without getting a CT scan first. So everybody gets a CT scan, and occasionally you have accidents in there in the CT scanner. So what happens in terms of the pathogenesis, briefly, there's a fecal-oral transmission of the spores. These spores that are released by C. difficile, they're practically indestructible. And when you have a diarrheal movement, and supposedly do away with it by flushing the toilet. Unfortunately, when you flush the toilet, you actually aerosolize everything in the toilet bowl, and it creates, everybody's familiar with aerosols now with the COVID-19 epidemic. You create an aerosol spray that spreads all the way across the bathroom, involving every surface in the bathroom. And one interesting story that had come up, a case report a number of years ago, was a mother of a Girl Scout troop. Formerly, the Girl Scouts used to distribute cookies and sell them. She didn't have much room in her apartment, so she stored it in her bathroom, all the supplies of the cookies for the Girl Scout troop. And someone had C. diff, and of course, all the packaging was contaminated with the spores, and there was an outbreak. All the customers to whom they were sold of C. diff in that community. So it was interesting how they backtracked it to that. But so the spores can survive the gastric acidity, and microorganism cannot. In the small intestine, the spore germinates, and in the large intestine, the spore can activate. Now, it can germinate, if you will, and if it finds an environment that's favorable for it, that is to say, an altered microbiome, it can actually change into a vegetative state. That is to say, a disease-causing, spore-forming organism that releases toxins as well as releases spores. Interestingly, if the C. diff encounters an intact microbiome, it does not. It can sense the actual environment, and it doesn't change into a disease-causing state. And in that circumstance, it becomes, if you will, a law-abiding citizen of the microbiome. It exists, but does not cause illness at that point. So again, this is a recapitulation of that last slide, but just to emphasize steps 3 and 4 is that there has to be an altered microbiome that's present in order for this C. diff to lead to an infection. And then in the course of that infection, various toxins that are released by C. diff that damages the epithelium, leads to further fluid secretion and dissemination of the spores through the course of diarrhea. Now, this is data collected by the CDC, last published in 2015. I guess they've been busy the last 3 years, but at the last time this was tabulated, 450,000 cases across the United States. The majority, almost 300,000, were healthcare associated with hospitals, urgent care centers, nursing homes. The rest are community acquired, but when those community acquired infections are looked at, usually there's a healthcare personnel associated with it in some fashion. There's almost 30,000 deaths a year. That has not changed. About $5 billion in excess costs associated with C. diff. And a component of acute C. diff is recurrent C. diff, a recurrence of the original infection. And this occurs in a significant percentage, and about 90,000 occurrences per year, adding an additional $1.5 billion to overall costs of the health burden of C. diff. And just to dwell for a moment on this concept of recurrent C. diff, after the initial infection, 25% of people will have a recurrence. That is to say, the original infection will recur, and the reason is this. Even though an individual with acute C. diff may be treated with an effective antibiotic, the spores that were released continue in the environment and continue within the GI tract. And as a consequence of therapy for acute C. diff, the microbiome is damaged more. And so when the course of antibiotics is completed, the spores regerminate and another infection begins. And with each new infection, the chance of a recurrence becomes greater and greater. So after 2 recurrences, we get up to greater than 50% recurrence rate, sometimes 80, 90% recurrence rate. So it becomes a terrific frustration for everybody, patient as well as physicians.